Hello student, now we are going to discuss another important topic, that is GFR or glomerular filtration rate. The first thing that you have to understand is glomerular filtration barrier. Okay, so there is a barrier through which filtration occurs at the level of glomerulus. That you have to understand, the structural part. So look at this diagram. Suppose this is your afferent arteriole. Okay, it is giving rise to glomerular capillary. So the schematic diagram of the glomerular capillary, and this is the efferent arteriole. So all of you know that the diameter of the efferent arteriole is little lesser than that of the afferent arteriole. Okay, and this glomerular capillary are surrounded by Bowman's capsule. So this is the Bowman's capsule. Okay, the layer of the Bowman's capsule which is in contact with this capillary, they are known as the visceral layer of the Bowman's capsule. So this is the visceral layer of the Bowman's capsule. And the layer which is not in contact with this capillary, glomerular capillary, that is known as the parietal layer of the Bowman's capsule. So this is the parietal layer of the Bowman's capsule. You know this structural part. Now just think that one substance has reached here through the circulation, and this substance is permeable to the glomerular capillary. So how it is going to pass through from this blood or the plasma up to the level of this Bowman's capsule, and that is nothing but filtration. So it has to pass through certain layers, and those layers is nothing but glomerular filtration barrier. So what are the different layers? So first of all, these substances has to pass through in between the endothelium cell of the capillary. So I am drawing the endothelium cell of this glomerular capillary. So the substances first has to pass through in between two endothelium cell. So what kind of endothelium cells are present at the level of glomerular capillary? They are fenestrated in nature. So the first layer of this barrier, so I am writing here, so this barrier is consisting of number 1, endothelium cell of glomerular capillary. Because it is a fenestrated type of endothelium, the gap which is present in between two endothelium cell is 70 nanometer. So big gap. So these substances will easily pass through this big gap between two endothelium cell. The next layer that it is going to encounter is nothing but the basement membrane of this endothelium cell. So now I am writing the second layer through which these substances has to pass through is the basement membrane layer. So I am writing here, that is the BM layer, basement membrane layer. So this basement membrane, it is mainly composed of type 4 collagen, and that is not continuous. There will be little gap in between this basement membrane layer also, and the gap is in and around 10 nanometer, right? Now after crossing through this basement membrane, the next layer that it is going to encounter, the substances that is going to encounter, is the visceral layer of the Bowman's capsule. The visceral layer of the Bowman's capsule is lined by a peculiar type of cell. So the cell I am drawing here, this cell which is lining the visceral layer of the Bowman's capsule is known as podocyte. So this cell is known as podocyte cell, right? So the third layer through which the substances has to pass through is foot process of podocyte. Foot processes of podocyte, right? So as you can find out here, if you look at a single podocyte, so the podocyte is looking like this, with some long processes. These processes are known as the foot processes of podocyte. So the substances will pass through the endothelium layer, then it will pass through the basement membrane, and then it will pass through this foot process of podocyte, and then the filtration will occur. So if I ask you, what is the gap which is present in between these two foot process of podocyte? This gap is known as filtration slit or this is also known as slit pore. This is known as slit pore. The gap which is present in this slit pore or filtration slit is 25 nanometer. But this slit pore is not completely open. There is a thin membrane which is present at the level of this slit pore. So there is a thin membrane which is guarding this slit pore, and this thin membrane is known as the slit diaphragm, right? So I'm writing here the thin membrane which is present at the level of this slit pore is known as slit diaphragm. Okay, slit diaphragm. And the gap which is present in this diaphragm also. So the diaphragm is also not a continuous barrier. It also contains small gap, and the gap which is present in this slit diaphragm is 4 to 14 nanometer, right? So you know that this slit diaphragm means it is nothing but a membrane-like diaphragm which consists of various proteins. And you know, the proteins which is forming this slit diaphragm, you have to remember the name of this protein. Number one, I'm writing here nephrin. Okay, you must have heard this name of this protein, nephrin protein, which is forming this slit diaphragm. Podosine protein. Okay, podosine protein, right? Not only that, alpha actinin protein, right? Why I have to remember these proteins? Because you know, if there is a mutation of this protein, okay, rather than protein mutation, there will be mutation of the genes which is coding this protein. The genes which is coded by this nephrin protein, okay, is NPHS1 gene. It is coding the protein nephrin, and NPHS2, this gene is coding the protein podosine, right? If there is mutation of this NPHS1 gene, then the gap will not be there. The gap will be large gap, and that will produce certain diseases. These diseases is known as congenital nephrotic syndrome of Finney type, right? Congenital nephrotic syndrome of Finney type. If there is mutation of this podosine gene, then it will produce steroid resistance, okay, nephrotic syndrome. If there is mutation of the alpha actinin gene, there will be other syndrome, other diseases like focal segmental glomerular sclerosis, the sporadic variant of focal segmental glomerular sclerosis. That's why this slit diaphragm is very important. You know that whenever there is mutation of the protein which is forming the slit diaphragm, there will be various renal pathology, like for example this disease that I have talked about. Right. So now we have understood that there are 3 layers in the filtration barrier. Okay. And if you look at this 3 layer, the minimum gap in this layer is 4 nanometer. Okay. The gap in the basement membrane is 10 nanometer, and the gap which is present in the slit diaphragm, the minimum gap is 4 nanometer. But not only gap. Whenever you are thinking of filtration, you also have to think of charges of this filtration barrier. So the filtration barrier consists of 3 layers. Look at the endothelium cell. Endothelium cell, they are lined by, they are under the covering of glycocalyx. And this glycocalyx composed of GAG, that is the glycosaminoglycan. What kind of charge it holds? Negative charge, right? So the endothelium cell surface, they are also negatively charged. Basement membrane, the important substances which is present here is the heparan sulfate proteoglycan. This has been asked in MCQ. Heparan sulfate proteoglycan. What kind of charge? Again, it is negatively charged. And if you look at the food process of podocyte, it also under the covering of negatively charged glycoprotein, right? So the glycoprotein covering is there, which is also negatively charged. So now if I ask you that glomerular filtration barrier contain which kind of charge, all of you know this information, that this barrier is a negatively charged barrier. Okay, and where this negatively charge is present, the negative charge is present in all three layers of this filtration barrier. Not only the endothelium cell, not only the basement membrane, the food processor podocyte also contain negatively charged substances, right? So this is all about the glomerular filtration barrier. Now, if you look at the gap that I already told you, the minimum gap is 4 nanometer. So, if a substance has a large diameter, then that substances will not be able to penetrate through this filtration barrier. And obviously, if the diameter or the radius is very less, it will easily pass through. Depending on this nature of filtration, there are three different kind of substances at the level of barrier. Number one, freely filtrable substances. Freely filtrable substances at the level of glomerular barrier. If the molecular radius is less than 1.8 nanometer, please remember, I am talking about radius. If I am saying it is in diameter, then you have to double it. Okay, 1.8 nanometer is the radius. If the radius of the substances is less than 1.8 nanometer, then this substances is freely filtrable without any hindrance, without any problem at the level of glomerular filtration barrier. Freely filtrable substances mean the molecular radius should be lesser than 1.8 nanometer, right? So this substances is freely filtrable, means whatever may be the charges of these substances, it may be negatively charged, it may be positively charged, but it will easily pass through. Okay. The examples of these freely filtrable substances, all of you know that your sodium, your potassium, okay, your water, your urea, okay, the creatinine, all of them are freely filtrable, including your inulin, okay, para amino hippuric acid, bicarbonate, all of them are freely filtrable because their molecular radius is less than 1.8 nanometer. Now, if the molecular radius is between 1.8 nanometer to 4.2 nanometer, they are known as selective permeable substances. Selective permeable substances. What will be the molecular radius? Remember, the molecular radius will be in between 1.8 nanometer to 4.2 nanometer. If this is the molecular radius, then these substances are known as selective permeable substances. What do you mean by that? If a substance's radius is falling in this range of 1.8 to 4.2 nanometer, then the filtration of these substances will depends on what is the charge which is present on the substances. Like for example, look at this diagram. Suppose I am talking about one positively charged substances, one negatively charged substances. Okay, positively charged, negatively charged. This positively charged substances will be attracted toward this filtration barrier because this filtration barrier is a negatively charged. But these negatively charged substances, this will be repulsed by this filtration barrier because negative charge will be repulsion. Okay, so this way, if the molecular radius is within this range, then the filtration of the substances will be determined by the charge which is present on them. If the substances is positively charged substances, if the substances is a neutral one without any charge, and if the substances is a negatively charged, the maximum filtration will occur in case of cationic or positively charged substances, followed by neutral or without any charge, followed by negatively charged. Means negatively charged substances means there will be least filtration within this radius range, right? So what are the examples of these selective filtrable substances or selective permeable substances? Albumin, right? Albumin, not only albumin, the hemoglobin. If the hemoglobin is free in your blood, right, they will be filtrated because their molecular radius is within this range. Not only that, the myoglobin, right, you have to remember this, myoglobin is also selective permeable. Not only that, the Baines-Jones proteins, okay, Baines-Jones protein, they are also in this selective range substances. Now, if you look at this albumin, albumin has a molecular radius of 3.55 is the molecular radius of albumin. So obviously you can find out that this is falling within this range of 1.8 to 4.2 nanometer. That's why albumin is a selective permeable substance. But if you look at the charge of the albumin at a physiological pH, all of us know that albumin contain negatively charged. So that's why we know that the filtration of albumin at the level of glomerular filtration barrier is very less, not nil. There will be certain amount of filtration of albumin even at the level of glomerulus, normal glomerulus I'm talking about. Okay, so look at, so suppose this is your Bowman's capsule, okay, and albumin is getting filtered, but very lesser in amount because of the negatively charged which is present on it, right? But even after filtration of this albumin, all of this albumin will not appear at the level of urine. Why? Because even after filtration, certain amount or most of the albumin will be reuptake by two receptor protein, and they are known as megalin and cabilin, C-U-B-I-L-I-N. So this megalin and cabilin, these are the proteins which helps in endocytosis of this albumin. So megalin and cabilin is helping in endocytic reabsorption of this albumin, because of which the amount of albumin which is present ultimately in your urine normally is only 8 to 10 milligram per day. Very smaller in amount. So all the albumin is getting filtered a little bit, but most of the filtered albumin will be reabsorbed by receptor mediated endocytosis, and these receptors are known as megalin and cabilin. And after that, the minimum amount of albumin which is present in the urine, which is normal, is 8 to 10 milligram per day. Right. If the amount of albumin is increased to 30 to 300 milligram of albumin, suppose this much of albumin is appearing in your urine per day, this is known as microalbuminuria, right? And this indicates that there obviously presence of renal pathology is there. And if the urine albumin is greater than 300 milligram per day, then this is overt proteinuria, and it indicates advanced renal disease is present, right? So this way you have to remember that freely filterable substances means it will be easily filtered without any hindrance. Selective permeable substances means, okay, the filtration will depends on the charge of the molecule, and if the molecular radius is beyond this 4.2 nanometer, then they are known as impermeable substances. So impermeable substances means if the molecular radius is greater than 4.2 nanometer. Okay, no filtration is possible if the molecular radius is greater than 4.2 nanometer. So there are three groups of substances: freely filterable, selective permeable, and impermeable, depending on the molecular radius. This you have to remember at the beginning of this GFR. Now the second thing that we are going to discuss is what is the net force for filtration, right? So whenever the filtration is occurring, someone has to push the molecule through this barrier, and then only the filtration is going to happen. So how much is the net forces which is pushing the molecule for filtration? That is the net force for filtration. Okay, so try to understand. Again the schematic diagram, similar kind of. So afferent arteriole, glomerular capillary, and the efferent arteriole, right? And Bowman's capsule is surrounding it, right? So there will be certain pressure due to presence of water inside your blood, and that pressure is known as the hydrostatic pressure. So what I am saying, through this afferent arteriole, the blood is coming, and the blood contains huge amount of water. Due to water content of the blood, the pressure which will be exerted on the vessel wall, that is nothing but hydrostatic pressure. So the hydrostatic pressure is denoted by the letter P. The hydrostatic pressure of capillary is Pc. Always remember that this hydrostatic pressure is a kind of pushing force, means it will try to push the fluid from this capillary compartment towards the Bowman's capsule compartment. So P indicate the hydrostatic pressure, right? Similarly, the Bowman's capsule also contains certain amount of water because always the filtration is going on. So water means again there will be hydrostatic pressure inside the Bowman's capsule also. So the hydrostatic pressure of the Bowman's capsule, suppose I am writing PB. B stands for Bowman's capsule. So the hydrostatic pressure of the Bowman's capsule will try to push the fluid in the opposite direction, right? So if I ask you, what is the net hydrostatic forces? Net hydrostatic forces. Obviously, we will say that PC minus PB is the net hydrostatic pressure at the level of this capillary. Now, not only hydrostatic pressure, you have to think of another pressure which is known as the oncotic pressure, denoted by this pi. Oncotic pressure. Okay, all of you know that oncotic pressure means nothing but it is the osmotic pressure exerted by the plasma proteins, right? Mainly the albumins. So this capillary blood will contain the plasma protein. Obviously, albumin will be there. So there will be an oncotic pressure at the level of this capillary. Suppose that is pi C. And oncotic pressure of the Bowman's capsule, suppose that is pi B. Oncotic pressure, it is a kind of retaining force. It will try to hold the water inside the same compartment, right? So oncotic pressure of this capillary, it will try to hold the water inside this compartment. That means I can understand as if it is trying to drag water from the other compartment. It is holding the water in the same compartment. So as if it is dragging the water from the Bowman's capsule compartment. So it is dragging the fluid in this direction. And the same way, the oncotic pressure of the Bowman's capsule will try to drag fluid from the capillary compartment. So now, if I ask you, what is the net oncotic force which is acting from this capillary towards the Bowman's capsule? Now I am asking, what is the net oncotic force which is acting from capillary towards the Bowman's capsule? Your answer will be pi B minus pi C, because pi B is trying to drag fluids towards the Bowman's capsule and pi C is obstructing that or obscuring that, right? So now, if I ask you, what is the net force at the level of glomerular capillary? You will say that it is combination of hydrostatic pressure plus oncotic pressure. So this is the total net forces which is acting at the level of glomerular capillary. This kind of forces, this kind of equation was first time discovered by Stirling. That's why this is known as the Stirling law or Stirling formula, right? So the Stirling law or Stirling formula is not only applicable in the glomerular capillary, it is applicable in every capillary, right? But here in the glomerular capillary, outside the capillary, the Bowman's capsule is there. But in the normal capillary, in the tissue, there will be presence of tissue outside the capillary, right? That is the basic difference. So now, if you look at this net forces, that is PC minus PB plus pi B minus pi C. So I have to put some normal value of each of these forces. So what is the normal hydrostatic force of glomerular capillary? The answer is 60 millimeter of mercury according to Guyton. What is the hydrostatic pressure at the level of Bowman's capsule? That is 18 millimeter of mercury. Plus, what is the oncotic pressure at the level of Bowman's capsule? So I told you already that oncotic pressure depends on proteins, plasma proteins. If I ask you how much amount of plasma protein will be filtered at the level of Bowman's capsule, your answer will be almost nil. So if the filtration of the plasma protein is almost nil, so the pi B will be near equal to 0 millimeter of mercury. But what about the pi C? Oncotic pressure of the glomerular capillary, that is 32 millimeter of mercury. So now if you calculate from here, this will be nothing but 10 millimeter of mercury. And this is an important MCQ. Please remember that the question will be like this, that the net force for filtration at the level of glomerular capillary is 10 millimeter of mercury. This is the average forces. Okay, there are certain controversy in some guidebook, but please remember that the net force for filtration at the level of glomerular capillary is 10 millimeter of mercury. Now, if you look at Genong, Genong has described these forces in a different way, and Genong is clearly saying that although the average force of filtration is 10 millimeter of mercury, but the filtration is not equal in every part of this capillary. What I am saying? I am asking you, try to understand that if I ask you that filtration will be maximum at the level of the beginning of this capillary, or at the middle portion of the capillary, or at the end portion of this glomerular capillary, where the filtration will be maximum, where the net filtration force will be maximum, right? Okay, so try to understand this topic like this. Suppose there is 700 ml of plasma reaching at the level of afferent arterioles level, right? From the afferent arteriole, it is entering at the glomerular capillary, 700 ml of plasma. That is the normal flow. Within this 700 ml of plasma, suppose there are presence of 100 molecules of albumin protein. So this 100 molecules of albumin proteins is giving the oncotic pressure of the capillary, right? Now, when this 700 ml of plasma is flowing through this glomerular capillary towards the efferent arteriole ends, what will happen? That some of the plasma is going to be filtered. That is the normal GFR, filtration. Some of the plasma is going to be filtered. So whenever the volume of plasma which is reaching in the efferent end, obviously there will be reduction in the total volume because of the filtration. So suppose 600 ml of plasma is reaching towards the efferent end. But what about this albumin which was present inside this 700 ml of plasma? 100 molecule of albumin was there. So what will happen? The same 100 molecule of albumin will present towards the efferent end of the capillary, but the volume of plasma is less. So the concentration of albumin is increasing towards this efferent end. If the concentration of albumin is increasing, what will happen to the oncotic pressure of the capillary towards the efferent end? Oncotic pressure of the capillary will increase. So I can understand that oncotic pressure of the capillary is increasing from this afferent end towards the efferent end. And if the oncotic pressure of the capillary is increasing, it will causes problem in filtration, means filtration force will be lesser. That's why we can easily understand that the minimum filtration is going to happen at the level of efferent end of this capillary, and the maximum filtration is going to happen at the level of afferent end of the capillary, right? And the average force of filtration is how much? That is a 10 millimeter of mercury. This is almost at the middle part of the capillary. So the maximum force of filtration, where I told you, maximum force of filtration is at the level of afferent arteriole end, okay? And that is 15 millimeter of mercury. It is the net force. And the minimum force of filtration is towards the efferent end, okay? The origin, the efferent end arteriole where it is originating, that is the area where the force of filtration is minimum. And how much that force is? That is almost 0 millimeter of mercury. That's why we know that whenever the blood or the plasma is flowing from afferent towards the efferent arteriole, the filtration will stop after, okay, the end of this capillary. So this way you have to remember that if this is your glomerular capillary, suppose this is the glomerular capillary, okay, filtration is maximum here and filtration is gradually decreasing towards the efferent end, and it is absolutely zero at the level of efferent arteriole starting. Okay, so this way you have to remember that net force of filtration, if that is the question, then that is the average force of filtration, and how much that is? That is only 10 millimeter of mercury. But whenever they are asking about the maximum force of filtration, your answer will be 15, okay, and minimum force of filtration, that is 0 millimeter of mercury, okay. Now you know that GFR, okay, is the net filtration force multiplied by a constant that is known as Kf, filtration coefficient. So what I am saying that normal GFR is equal to net force of filtration multiplied by Kf. So Kf is a constant. I have to derive the value of this constant. So put the normal value of the GFR, that is 125 ml per minute, right? That is the normal value of GFR. Net force of filtration, just now we have calculated, that is 10 millimeter of mercury multiplied by Kf. So obvious thing is that Kf is equal to 12.5 ml per minute per millimeter of mercury. So this is a constant. This constant is known as filtration coefficient. Filtration coefficient. This filtration coefficient depends on two parameters that you also have to remember. And what are they? Number one, that is the total surface area of glomerular capillaries. Okay. And second one is the permeability of glomerular capillaries. Okay. So these are the two parameters on which the constant, that is the Kf, filtration coefficient, depends. So you can easily understand from this equation that due to any reason, if the Kf is changing, then GFR will also change. If the Kf is decreasing, the GFR will decrease. So if there is decrease in the total surface area of the capillary, like for example, suppose some of the capillaries are getting sclerosis, focal segmental glomerular sclerosis. So what will happen? This filtration coefficient value, that is the Kf value, will decrease, and because of that, the GFR value will also decrease, although your net filtration pressure may be normal, right? Similarly, if there is change in the capillary permeability due to deposition of certain molecule on the capillary membrane or basement membrane, wherever, then also there will be decrease in GFR, right? So this way you have to remember that the net force of filtration and Kf, these two are the important parameter which is determining your GFR. Now, you think of certain normal value. I told you already that the total volume of plasma which is flowing in the glomerular capillary in 1 minute is 625 to 700 ml. What is this? This is nothing but normal renal plasma flow, RPM. And what is the normal GFR? That is 125 ml, okay, per minute. That is the normal GFR. Both the value in 1 minute only. So if I take a ratio between these two, GFR upon this renal plasma flow, this ratio is known as FF, which is that, what is that? That is nothing but filtration fraction. This is nothing but known as filtration fraction, right? So if you put this normal value of GFR, that is 125 ml here and 625 or 700 ml here, then the filtration fraction will be 0.16 to 0.2, or you can say this is nothing but 16% to 20%. What is the meaning of that? Meaning is that in 1 minute, whatever amount of plasma is entering in your glomerular capillary, within that volume of plasma, only 16 to 20% of plasma will get filtrated in 1 minute. That is the meaning of this filtration fraction. So filtration fraction is an MCQ. You have to remember GFR upon renal plasma flow is nothing but your filtration fraction, right? Now after discussion of this GFR and the factor which is determining the GFR, now we have to discuss what are the regulator of GFR, means how the GFR is regulated. Okay, so the important topic is regulation of GFR. Regulation of GFR, glomerular filtration rate. Okay, you remember like this. Regulation of GFR means number one, auto regulation. Okay, and number two, afferent and efferent arterioles resistance. Okay, So if you causes constriction or relaxation of the afferent or efferent arteriole, then also GFR will change, GFR will be regulated, and the auto-regulation. Okay. So these two are the major regulator of GFR. First, we are going to understand auto-regulation of kidney. Okay. So auto-regulation, whenever I will say like this, what you are thinking of? Auto-regulation, auto means self. So what is regulated? If I ask you a question like this, the auto-regulation means constant blood flow, constant blood pressure, constant blood velocity, constant blood viscosity. You know that it is nothing but constant blood flow irrespective of your blood pressure. What I'm saying? By definition, auto-regulation means, you look at, auto-regulation means if I draw a diagram or graph like this, okay, auto-regulation curve, okay. So x-axis is the blood pressure of the subject, okay, and y-axis is renal plasma flow, okay, renal plasma flow. So blood pressure means which blood pressure you are talking about, sir? Mean blood pressure. So the graph will look like this. The graph will look like this, okay. So in this graph, what this graph is indicating? This graph is indicating that if the blood pressure of the person is changing from 80 to 180 millimeter of mercury, if the blood pressure is changing between this range of 80 to 180 millimeter of mercury, is there any change in renal plasma flow? Answer is no. There is a plateau. Plateau means no change in renal plasma flow is occurring if your blood pressure is changing between 80 to 180 millimeter of mercury. So kidney is maintaining a constant plasma flow inside the structure irrespective of your blood pressure. That's why I told you that autoregulation means it is the constant maintenance of blood flow in an organ irrespective of the blood pressure, but obviously within a particular range. If the blood pressure is going beyond this range, suppose the blood pressure is below 80 millimeter of mercury, suppose one person is suffering from cardiogenic shock, there will be renal shutdown. Obviously, why? Because this lowering of blood pressure which is beyond this autoregulatory zone, okay, kidney will not be able to maintain the blood flow if the blood pressure is going below 80 millimeter of mercury. And similarly, if the blood pressure is going above 180 millimeter of mercury, then also there will be auto-regulatory failure. Kidney will not be able to maintain its own blood flow constant. So within this range of 80 to 180 millimeter of mercury, kidney is maintaining a constant blood flow. And if the blood flow or the plasma flow is constant, what will happen to the GFR? GFR will also remain almost constant. That's why we say that in case of kidney, GFR is also auto-regulated, as well as the renal plasma flow is also auto-regulated. So this is known as auto-regulatory curve. Within this auto-regulatory zone, there is no change in renal plasma flow. Right. So kidney is a vital organ. You have to maintain this kind of mechanism. Okay. But the question is, what is the mechanism? So if I ask you, kidney is maintaining its own blood flow. It has a strong auto-regulation, well and good. But what is the mechanism? How it is doing that? So mechanism of auto-regulation. Mechanism of auto-regulation, right? Okay. There are two mechanisms and both of them are very, very important for MCQ. Number one mechanism is known as myogenic mechanism. Myogenic mechanism, right? And number two mechanism is known as tubuloglomerular feedback mechanism. So this is a kind of feedback mechanism. Tubuloglomerular feedback mechanism, or TGF. So for the time being, you remember myogenic mechanism is mediated through calcium, and tubuloglomerular feedback mechanism is mediated through a substances which is known as adenosine. Both has been asked in AIIMS entrance examination. That's why you have to remember at least that what is the mediator of this mechanism, even if you don't remember the detailed version of the mechanism. The mediator of myogenic mechanism is calcium, and the mediator of tubuloglomerular feedback is adenosine. Now, what is myogenic mechanism? If I say myogenic, what are you thinking of? Myo, muscles. So this is something related to smooth muscles of afferent arteriole. So if I ask you, myogenic mechanism means how I am going to understand. Myogenic mechanism is occurring at the level of smooth muscles of afferent arteriole. Smooth muscles of afferent arterioles. Getting my point? Now, how this mechanism is operating? So now we are going to detailed version of this mechanism. Suppose one person is suffering from high blood pressure. Suddenly the blood pressure is rising. So whenever the blood pressure is rising, it will cause a stretch on the blood vessels, every blood vessel. So obviously the afferent arterioles will also get stretched. So suppose this is the afferent arteriole, and due to increase in blood pressure, it is causing, the blood pressure is causing stretching of this afferent arteriole. Now whenever there is stretch of this afferent arteriole, we know arteriole means they are oval, composed of very thick layers of smooth muscle. So there will be smooth muscle cells here, there will be smooth muscle cells here, right? So what happens whenever there is stretch of this afferent arteriole, the individual smooth muscles which are present at the level of the wall of this vessel, they are also going to get stretched. So there will be stretching of these smooth muscles. So this is my smooth muscles. Now whenever there is stretch on these smooth muscles, smooth muscle membrane contain certain stretch sensitive channels. Stretch sensitive channel means these channels will open in presence of mechanical stretch. So the stretch sensitive channel which are present here, they will open up, and through this channel which molecule is going to enter? This is a calcium channel. So the calcium will enter. So what I am saying, whenever there is stretch on these afferent arterioles, right, there will be stretch on smooth muscles of the afferent arteriole, smooth muscles of afferent arteriole. This stretch will leads to opening of calcium channels on smooth muscle membrane. This is known as stretch sensitive calcium channel. And whenever calcium is present at the cytoplasm of cells, what is going to happen? There will be contraction of smooth muscles. And whenever there is contraction of the smooth muscle, what will happen? There will be constriction. There will be constriction of these afferent arterioles. Simple. There will be constriction of this afferent arteriole. So what you are saying? You are saying that whenever the afferent arteriole is stretched, due to contraction of the smooth muscle, the afferent arteriole will again get back to its normal size. This mechanism is mediated by smooth muscle contraction, or it is mediated by smooth muscles. That's why the mechanism is known as myogenic mechanism. So you stretch the vessel, blood pressure is stretching the vessel. Whenever the vessel is stretched, the GFR is going to rise, because whenever this blood pressure is stretching the afferent arteriole, there will be more blood flow to the kidney. GFR is going to rise. But within few minutes, what will happen? There will be constriction of the afferent arteriole via this myogenic mechanism. And whenever there is constriction of the afferent arteriole, GFR will normalize once again. This is known as myogenic mechanism. Now this tubuloglomerular feedback mechanism, this mechanism will be discussed in the next chapter, that is the chapter of JG apparatus, right? So forget about this mechanism for the time being. Now you concentrate on the second mechanism of autoregulation. So now we have discussed this autoregulation. We know what is the meaning of autoregulation and how the autoregulation is done at the level of kidney. Now we are concentrating on the second part, that is the afferent and efferent arteriole resistance. Means if you causes constriction or dilatation of the afferent arteriole or efferent arteriole, how the GFR is going to change. Very important and very simple. So I'm writing here afferent arteriole Okay, constriction okay, and relaxation. Okay, and then efferent arteriole, constriction and relaxation. Okay, you have to answer that if there is constriction or relaxation of this afferent or efferent arteriole, what is going to happen about the renal plasma flow? What will happen in the GFR and what will happen in filtration fraction, FF, filtration fraction. I have told you what is filtration fraction. So this table is very, very important for your MCQ. Now think of afferent arteriole, very, very easy. All of you will be answering. Okay, so afferent arteriole, if you causes constriction, renal plasma flow will decrease. Proportionally, your GFR will decrease because hydrostatic pressure is going to down. Okay, going to be reduced. Afferent arteriole relaxation means renal plasma flow will rise, hydrostatic pressure will be increased, and GFR will also proportionately rise. So, if your GFR is also rising and renal plasma flow is also rising proportionally, what will happen to filtration fraction? It will remain normal. It will remain normal in both the cases. Okay. Now, the main problem arises whenever you are looking at efferent arteriole constriction. So, efferent arterial constriction, what is going to happen at the level of renal plasma flow and GFR? I know you know something about this, but you look at the concept, how you are going to remember this. Efferent arterial constriction, renal plasma flow, it will be reduced, but why? Look at, okay. So, whenever you are thinking about afferent arteriole or efferent arteriole, both of them are located inside the kidney. Okay, and kidney, you have to think of that kidney as a whole organ, and the heart is pumping blood to every organ, and kidney is one of them, right? So this is your heart, okay, it is pumping blood, okay, and it is supplying every organ. Suppose this is liver, okay, it is supplying the spleen also, okay, it is supplying others organ also, and in between the kidney is also there. And inside the kidney we have seen that there are two resistance vessels. One of them is the afferent arteriole and one of them is the efferent arteriole. Getting my point? Getting at the diagram? Okay, afferent and efferent arteriole, both are the resistance vessels. Both of them are located inside the kidney, and heart is pumping blood through every organ, right? If you causes constriction of afferent arteriole or efferent arteriole, both of these afferent and efferent arteriole, they are in a series circuit. Means if this is your R1, resistance R1, and this is R2, both of them are in series. Means the total resistance of the kidney is nothing but R1 plus R2. So if you causes constriction of the afferent arteriole, then also the total resistance will increase. If you causes constriction of the efferent arteriole, then also the total resistance of the kidney will increase. Means whenever you are constricting the afferent arteriole or efferent arteriole, whether you are rising your R1 or R2, the total resistance of the kidney will be higher than normal. Now, if your total resistance of the kidney is higher than normal, what will happen? The blood is not going to flow through high resistance organs. So, whenever the resistance of the kidney is high, the blood is not going to flow in the kidney. Rather, the blood will be diverted in the other organ like this. So, more blood will be diverting in the other organ rather than kidney. That's why whenever you constrict afferent arteriole or efferent arteriole, the total resistance of the kidney is rising. And if the resistance of an organ is high, obviously the blood flow is going to be reduced, because we know the Ohm's law, V is equal to IR. So that way, always, whenever you are thinking of renal plasma flow, think of the total resistance of the kidney. Constriction means always there will be decrease in renal plasma flow. So whether it is afferent or efferent, in both the cases, there will be reduction in the renal plasma flow. And if you causes dilation of the afferent or relaxation of the afferent or efferent arteriole, in both the cases there will be increase in renal plasma flow. Okay, so relaxation means obviously this is nothing but dilation. So if you causes dilation of the afferent or efferent, renal plasma flow is high. If you causes constriction of the afferent and efferent, renal plasma flow will reduce. Is that clear? Because the next portion is dependent on this concept only, right? Is that clear? Obviously. Okay. So now I am causing constriction of the efferent arteriole. Renal plasma flow will be reducing proportionately. In this reduced plasma flow, what will happen to the GFR? To understand this, you have to think of two scenarios. The constriction of the efferent arteriole, how much constriction you are doing? Mild constriction or severe constriction? So, look at this diagram. Okay, same schematic diagram everywhere. Okay, so this is efferent arteriole. I am causing constriction of this efferent arteriole, but that constriction is mild. Suppose I am causing constriction, mild constriction. Okay, mild constriction means if the resistance, okay, so whenever you are constricting, there is rising in resistance, there is increase in resistance of the efferent arteriole. If the resistance is below the twice that of the normal, okay, then that is known as a mild constriction. And if the resistance is rising more than twice, okay, more than twice the normal, then that kind of constriction is known as a severe constriction. Suppose you have constricted so much that the resistance has rise to 3 times that of the normal, that is a severe constriction. Okay, so up to 2, 3, that is a mild constriction. Greater than 3, greater than 2, greater than 3, that is known as a severe constriction. Okay, generally it is said that if the resistance is rising more than 3 times than that of the normal, then that is a severe constriction. Okay, so mild constriction. What will happen to the renal plasma flow? You first look at the renal plasma. Obviously, there will be reduction in the renal plasma flow. And how much? If the constriction is mild, then the reduction of the plasma flow will also be lesser. So, normally the renal plasma flow is 700 ml, that is a normal. If I causes mild constriction of this efferent arteriole, there will be reduction in the plasma flow. Suppose now this reduction is 500 ml. Okay, getting my point? So, because of the reduction of this renal plasma flow, now this is 500 ml. So, 500 ml plasma is flowing inside this glomerular capillary in 1 minute, and when this plasma is trying to go out of this efferent arteriole, it will not be able to go out easily because you have constricted the efferent arteriole. Getting my point? So, the plasma volume which is flowing at the level of capillary is lesser than normal. But that plasma is not able to going out of this glomerular capillary easily because efferent arteriole is constricted. So this 500 ml of plasma is going to stay here at the level of capillary for some more time, more than 1 minute. So what will happen? In the second minute, another 500 volume of plasma will reach here. Okay. So already approximate 500 ml of plasma is waiting there from the first minute, and in the second minute another 500 ml of plasma is coming in the level of glomerular capillary. When the third volume of plasma, in the third minute, when the third volume of plasma 500 ml is reaching in the glomerular capillary, the first 500 will already go out of this capillary. Getting my point? So in a steady state condition, in the first minute 500 is coming, in the second minute 500 is adding up with that, in the third minute when another 500 is coming, that is pushing the first 500 ml of plasma out of this capillary. This is for gross understanding. Okay, this is happening like that. So I can understand that in steady state condition, 500 ml of plasma was already there. Another 500 ml of plasma is adding up with this volume of plasma. So the total volume of plasma which is present at the level of glomerular capillary in this condition is 1000 ml approximately. So 1000 ml means this is more than normal volume of plasma. So what will happen to the hydrostatic pressure of the glomerular capillary? High. If the hydrostatic pressure of the glomerular capillary is high, what is going to happen to the GFR? GFR will rise. That's why we say that if you causes constriction of the efferent arteriole and that constriction is mild constriction, renal plasma flow will always reduce because the resistance is high. But what will happen to GFR? GFR will increase, right? That is the first one, mild constriction. Now, if you causes severe constriction of this efferent arteriole, right? So, severe constriction means resistance is rising more than 3 times than that of the normal. What will happen? What will happen to the renal plasma flow? First you think of that. Okay, you will think that the renal plasma flow will be reduced to very severe level. Answer is yes. Why not? So initially I told you mild constriction means the renal plasma flow reduced to 500 ml. Now suppose you are thinking of severe. So severe means renal plasma flow, suppose it has reduced to 200 ml, right? So now you will say that the same thing is going to happen here, sir, also. Yes, this 200 ml of plasma, it is not going to pass through this efferent arteriole easily. So it will stay back. So suppose this 200 ml of plasma is staying back here, right? So in the second minute, another 200 ml of plasma will reach here, okay? So in the second minute, another 200 ml of plasma is reaching here. In the third minute, when the third volume of plasma will reach here, it will already push the first 200 ml of plasma like this. The same understanding like that of the previous one. So 200 ml of plasma is staying there in the capillary. In the second minute, another 200 ml of plasma is coming up. So in steady state condition, total volume of plasma which is staying at the level of glomerular capillary is approximate 400 ml. This 400 ml is always lesser than normal volume. So what will happen to the hydrostatic pressure of the glomerular capillary in this condition? Decrease. If the hydrostatic pressure is decreased, what will happen to GFR? GFR will also decrease. That's why whenever you causes severe constriction of the efferent arteriole, renal plasma flow will reduce to a so low level that the normal GFR will not be maintained, and that's why in this condition the GFR will also fall. The Guyton is writing like this, that the constriction of the efferent arteriole, if it is severe, the RPF will reduce to a so low level that the normal hydrostatic pressure in the capillary will not be maintained. So the bottom line is that constriction of the efferent arteriole, always the renal plasma flow will reduce, but GFR will increase initially when the constriction is mild, then the GFR will reduce when the constriction is severe. Getting my point? So if the GFR is rising, then what will happen to this filtration fraction? Filtration fraction will also increase, and if the GFR is decreasing, filtration fraction will also decrease. Very simple, right? So FF rising, FF decreasing. Now you look at relaxation of the efferent arteriole or dilatation of the efferent arteriole. Always whenever I am drawing this diagram of the afferent and efferent arteriole, you must have seen that I have made this efferent arteriole diameter lesser than that of the afferent arteriole. Getting my point? So efferent arteriole diameter is lesser than the afferent arteriole. So if you causes dilation of this efferent arteriole, what will happen? Although the plasma flow in the capillary will be higher, but that high volume plasma will not stay at the level of this glomerular capillary. It will easily pass through this glomerular capillary. And if the high volume plasma is easily passing through this glomerular capillary, then the hydrostatic pressure will not be maintained at the level of capillary. And that's why the GFR will fall. So if you causes dilatation of this efferent arteriole, although the renal plasma flow is high, but GFR will decrease and the filtration fraction will also reduce. So this is the understanding that you have to keep in your mind whenever you are answering this kind of question. This is a very, very famous question which has been asked in multiple times in various MCQs, okay, various type of examination, right? So please remember this table very carefully. Now, if you look at the graphical representation, sometimes the image-based question can be given, okay? So if I plot some graph and if we try to understand this afferent and efferent arterial constriction, how it will look like, okay? So two graph I'll draw side by side, okay? In one afferent arteriole will be constricted and in one efferent arteriole will be constricted. So if I causes constriction of the afferent arteriole, so x-axis is afferent arteriole resistance, right? So suppose this is the normal resistance, this is twice than that of the normal, and this is 3 times than that of the normal. Getting my point? Resistance. Okay. So you are causing constriction of the afferent arteriole more and more. So resistance is rising. What will happen to the renal plasma flow and GFR? Tell me. Both of them will reduce. So there will be continuous, there will be progressive reduction of the GFR. Suppose this is GFR, and there will be progressive reduction of the renal plasma flow. Very simple graph. Okay, renal plasma flow RPF. Okay, this is typical of afferent arterial constriction graph. But if you look at the efferent arterial curve, so again same thing. This is the efferent arterioles resistance. Okay, this is efferent arterial resistance. Okay, this is normal, this is twice than that of the normal, this is 3 times than that of the normal. We know that more you constrict the efferent arteriole, more you increase the resistance of the efferent arteriole, what will happen? Renal plasma flow will progressively decrease like this. Okay, so this is not a good one. So there will be progressive decrease in the renal plasma flow. So this is my RPF. But if you look at the GFR, I already told you that mild constriction means GFR will rise initially, and then if you go towards the severe constriction, GFR will reduce, right? So that's why you are finding out the curve is like that, that initially the GFR is rising, but later on the GFR is going on reduced more and more. So this is all about the regulation of GFR, which is done by afferent and efferent arterial constriction. So we have discussed so many things about the GFR and its regulation. Now I'll talk about some other factors, okay, other mediators which are also responsible for regulation of your GFR, various other substances, right? Like for example, here you are finding out various vasoconstrictor and various vasodilator. Okay, so within this vasoconstrictor you are finding out angiotensin 2, okay, sympathetic nerve and endothelium. All of them are potent vasoconstrictor. Okay, they can cause constriction of the afferent as well as the efferent arteriole. So what will happen to your GFR and your RPF? You are finding out that in all 3 cases there will be decrease in GFR also, and in all 3 cases there will be reduction in the RPA, I mean renal plasma flow also. But if you look at the vasodilator, okay, the first vasodilator that is given here is the prostaglandin. Okay, prostaglandin causes increase in renal plasma flow and increase in GFR, or there may be little change in GFR or maybe no change in GFR. But renal plasma flow rises. But you have to remember one condition here. Prostaglandin increases your renal plasma flow or GFR in pathological condition only, not in normal condition. In pathological condition, so please remember the effect of prostaglandin is mainly during the pathological condition. Like for example, one person is suffering from severe hemorrhage, right? So whenever the person is suffering from severe hemorrhage, what will happen? There will be activation of the sympathetic system. That sympathetic system will produce huge amount of angiotensin. In these cases, when your sympathetic system is high, your angiotensin is high, prostaglandin will causes inhibition of the effect of this angiotensin 2 and sympathetic system. Means it will counteract the effect of angiotensin 2 and sympathetic system, and by this way it will causes vasodilatation by counteracting the effect of angiotensin 2 and sympathetic system. That's why it is said that in pathological condition, like for example during severe hemorrhage, prostaglandin is very important, because that is maintaining your renal plasma flow and that is also maintaining your GFR. In this condition, if you inhibit this prostaglandin production by giving NSAID kinds of drug, okay, which inhibit the prostaglandin production, that can be decremental, because they will reduce the production of the prostaglandin and your renal plasma flow and GFR will go down, right? So this way you remember that prostaglandin is very important during the pathological condition. Nitric oxide has similar kind of role, okay. It also counteract the effect of angiotensin 2 and sympathetic system mediated vasoconstriction. That's why it causes vasodilatation and RPF and GFR increases, right? Similarly, the bradykinin is a potent vasodilator. It causes increase in renal plasma flow as well as increase in your GFR, right? Now last one, the natriuretic peptide. All of you must have heard about this ANP, atrial natriuretic peptide. So what is the major source? We all know that ANP, the major source is the atrial myocyte, and BNP, the name of this peptide is brain-derived natriuretic peptide, because first time the peptides were discovered in porcine brain. That's why this is brain-derived natriuretic peptide. But if I ask you what is the major source of BNP in mammals or in our body, your answer will be ventricular muscles or ventricular myocyte. So atrial myocyte ANP and ventricular myocyte is producing BNP, brain-derived natriuretic peptide. Both of them has similar kind of functions. What are the functions? Vasodilator action. Because of the vasodilation, it causes increase in GFR, but there is a catch here. ANP and BNP, it causes vasodilation particularly of afferent arteriole. So afferent arteriole will be dilated and efferent arteriole, it will get little constricted. So there will be constriction of the efferent arteriole and dilatation of the afferent arteriole. So what is the net effect? You are dilating afferent, so resistance is decreasing. You are constricting efferent, resistance is rising. There will be balancing, and that's why it is not changing the renal plasma flow. Little change in renal plasma flow because afferent arteriole dilated, efferent constricted. And because of the little change in plasma flow, GFR is also not changing significantly, but it is said net result on GFR is little rise in GFR in presence of ANP and BNP, right? So now in this chart, you must have looked at this angiotensin 2, right? So I told you that angiotensin 2 causes reduction in GFR, reduction in the renal plasma flow. Many of you are thinking that is that a correct information? The angiotensin 2 causes reduction in GFR. Answer is yes. Look at what Goodman-Gilman is saying. So this is direct image from Goodman-Gilman. Effect of angiotensin 2 on GFR. Okay, it has many effects. It is a vasoconstrictor, protein vasoconstrictor. Which vessel will be constricted? It causes constriction of the afferent arteriole. So if you causes constriction of the afferent arteriole, what will happen? The GFR will reduce. Not only that, it also causes contraction of the mesangial cells. Okay, we will be discussing these mesangial cells in the next chapter. Contraction of the mesangial cells will also reduce the GFR. Not only that, it also causes constriction of the efferent artery also, which is tending to increase the GFR. So, by constricting the afferent arteriole, it is trying to reduce the GFR. By contraction of the mesangial cell, it is trying to reduce GFR. And by constriction of the efferent arteriole, mild constriction, it is trying to increase the GFR. So, two effect is trying to reduce the GFR. One effect is trying to increase the GFR. What will be the net effect? The net effect will be reduction of GFR a little bit in normal condition, and that is clearly written in Goodman-Gilman here in the next chapter. That is, normally GFR is slightly reduced by angiotensin 2. In which condition? Normal condition. But if there is certain kind of pathology, okay, he is writing in the second line. However, during the renal artery hypotension, you think of renal artery stenosis. Whenever there is renal artery stenosis, in this condition, angiotensin 2 effect is different. What is that different? In this condition, the effect of angiotensin 2 on efferent arteriole dominate. What is the effect of angiotensin 2 on efferent arteriole? It is trying to cause constriction, and by which it is trying to rise the GFR. That's why whenever the person is suffering from renal artery stenosis, in this condition, angiotensin 2 is beneficial. How beneficial? It is trying to increase your GFR, right, by constricting the efferent arteriole more than that of the afferent arteriole constriction. So, if you, block this angiotensin 2, then what will happen? Your GFR will fall, and that's why it is said that ACE inhibitor is contraindicated in this condition of renal artery stenosis, because if you give renal ACE inhibitor, it will causes decrease production of angiotensin II, and that will leads to reduction in GFR and renal failure may happen. And it is written here, thus the blockade of the renin-angiotensin system may causes acute renal failure in patient with bilateral renal arterial stenosis particularly. So this is clearly given in Goodman-Gilman. So please don't confuse. Angiotensin II is a potent vasoconstrictor and it causes constriction of both afferent and efferent. But efferent arterial effect dominate in condition of pathological condition like for example renal artery stenosis. So angiotensin II has many effects, and if you look at Goodman-Gilman a little more detail, you will be finding out many effects of angiotensin II. Okay, we know the common effect, that is the direct vasoconstriction, we know this, but apart from that it causes enhancements of noradrenergic neurotransmission. That means it increases the norepinephrine release, it decreases the norepinephrine uptake. Not only that, it also causes increased sympathetic discharge from CNS, and it also causes release of catecholamines from adrenal medulla. Okay, so not only the vasoconstrictor effect, it is stimulating the sympathetic system directly from the CNS. Okay, it is releasing the epinephrine and norepinephrine from adrenal medulla. All of these are done by the angiotensin II. Not only that, look at the second effect. It causes absorption of the sodium, or it causes increased sodium reabsorption from the proximal tubular epithelium cell. Sodium reabsorption is also done by angiotensin II. Not only that, it causes release of aldosterone from adrenal cortex. Not only the epinephrine and norepinephrine from adrenal medulla, but also aldosterone is also released by angiotensin II. And if you look at the long-term effect, then non-hemodynamically mediated effects are also there. What is that? Multiple increased expression of proto-oncogene, increased production of growth factor, increased synthesis of extracellular matrix. By this way, it can causes remodeling of certain organ like heart. So this way you have to remember that it causes remodeling of the cardiac chamber as well as remodeling of the vascular wall. So this way angiotensin II has many effects. You have to remember some of these effects for your MCQ. So this is all about your GFR and its regulation.